Hello friends, myself Dr. Ritesh Shah. I welcome you all on behalf of Indian Society of Critical Care Medicine for this another wonderful episode of VODCAST. Today's our expert is none other than Dr. Arunaloke Chakrabarti sir. There is no need to introduce him as he is well-known fungal figure, I would say, globally. But just to say a few words about him, he is the past president of International Society of Human and Animal Mycology, Indian Society of Medical Mycologists, Indian Association of Medical Microbiologists. He is now working as a director of Dudhdari Barfani Hospital and Research Institute, Haridwar. Earlier, he worked at PGI Chandigarh. While working, he actually developed the National Advanced Center in Medical Mycology that all of us were fortunate to witness. WHO Collaborating Center for Reference and Research on Fungi of Medical Importance. National Culture Collection of Pathogenic Fungi. So by and large, I would say that if I go on, I think whole episode would be insufficient to introduce him. He is having more than 550 papers on mycology across the world. I mean, it's phenomenal work. So on behalf of Indian Society of Critical Care Medicine, sir, thanks once again for accepting our invitation. And, it's a prestigious platform of ISCCM VODCAST. And we are honored that you are today's expert. And today we are talking about one particular thing is biomarkers of fungal infection. Very focused discussion. So Dr. Srishti Jain, my other, partner for taking this kind of interview, she's joining soon. Meanwhile, we'll just start the discussion. Thank you once again, sir, for accepting our invitation. So, sir, just to start, I mean, which are right now available just take it in a while. So which are the good biomarkers available in India?
First, I start good afternoon to all. At the outset, I'd like to thank ISCCM as well as Dr. Ritesh for giving me this opportunity to interact with you. The topic is very challenging, that is the fungal biomarker, because biomarker don't diagnose categorically any disease. It's more of a Bayesian probability. So this gives you an idea how much a chance of a particular disease. In that perspective, the critical care group where we are discussing today, the biomarkers which are available and commonly being used by most of the people in India is basically 3-4. One is this Beta-D-glucan, which is used in case of the Candida and Pneumocystis, though it can detect many other fungi, but it is not in case of Cryptococcus and also Mucor, it is being present. Next important thing is that the Galactomannan. And this Galactomannan is a major issue in case of the mold infection, especially identifying aspergillosis. And then we have a very common biomarker which we use, but people hardly say it is a biomarker, but that is cryptococcal antigen detection test. This cryptococcus antigen is very important biomarker test because I would say amongst all serological tests, cryptococcus antigen is the best both in sensitivity and specificity. Next, which we are coming across very soon or already some people have started using is point of care test. That is the lateral flow assay which had come up, and this lateral flow assay, especially in case of the aspergillus, would be very relevant in critical care. Of course, we are also using it. We have now replaced Candida cryptococcal antigen with lateral flow, and also in case of histoplasma, it is being routinely being used. So this is in scenario at present what we do have in case of biomarker in India.
Right. So I would say majority availability is of Galactomannan followed by Beta-D-glucan. And yes, Cryptococcus that you already mentioned that should be utilized more frequently than it used to be now. So, sir, as far as beta-D-glucan and galactomannan, what's the pathophysiology? Where it originates, as far as why it is very specific to fungus?
See, the thing is that in case of the galactomannan, which you have put it at the beginning or at the first, galactomannan is a presence in the fungal cell wall, or it is being secreted also while the fungal grow. So it is in case of the mold, it's present in many others, but the specific galactomannan which we are detecting, that had been found more in case of the aspergillus, but it is also being present in some of the other fungi, like in case of histoplasma, penicillium, even fusarium. So, this can help sometimes in diagnosing, like suppose if you don't have histoplasma antigen, you can use indirectly this galactomannan for diagnosing histoplasmosis in that scenario. And then it comes out when the fungi grow. So if you see in case of the critical care group, critical care fungi generally don't enter the blood vessels so quickly as happens in case of neutropenic patient. Because neutropenic patient, the neutrophil is not there, so fungi get opportunity to enter. So it goes in the tissue plane. And that's why galactomannan in case of the critical care group has not so much sensitive as we do see in other scenario, because it's not being present so high in amount. But what we can really improve, that is the BL galactomannan, that is much better in case of the critical care group in that sense. Beta-D-glucan also present in case of the fungal cell wall. And this beta-D-glucan is not only fungi, many other things which contains beta-D-glucan. That's why any test of this biomarker which has maximum false positive, that is we see in case of beta-D-glucan. So again, these things come in the blood or serum, which you can see whatever the amount that we try to detect. Now, I would say in case of the galactomannan a bit more, that galactomannan, as it is not going into the blood vessels, so serum galactomannan detection in case of the critical care group, non-neutropenic, I am discussing non-neutropenic group, is usually low. Whereas it is much better if you do in case of BL galactomannan. That is very important issue. That's also very important when you are discussing respiratory virus associated pulmonary aspergillosis, which is like kappa, that is COVID associated pulmonary aspergillosis, or influenza associated pulmonary aspergillosis. Serum galactomannan, that's the reason which is not so high positive. And generally, all the products is being taken away by the immunity. So if your immunity is very good, that is being taken away. That's another issue which has been there.
Right.
So in short, though, there are so many issues that there in pathophysiology, but for common understanding, we can go with this. Okay.
Yes. So, sir, as you said that beta-D-glucan is particularly for few fungi and galactomannan is for few fungi. Now, in critically ill patients, we have three sets of, more like mucor, aspergillus, and candida. So we'll go to maybe I'll discuss with clinical scenario, but by and large, among this, which is more specific, you had already told, but still to be very precise, suppose beta-D-glucan if we take, how much is the sensitivity and specificity for particular fungus?
See, the thing is that we generally discuss beta-D-glucan for diagnosis mainly in two conditions. One is the candidiasis, another is in case of the pneumocystosis. We don't diagnose aspergillosis with beta-D-glucan, but yes, in aspergillosis also beta-D-glucan increases. Why we are considering? Because in these two conditions, candida and pneumocystosis, the beta-D-glucan goes quite high. That helps in case of detection. But suppose the patient where you have got galactomannan positive as well as beta-D-glucan positive, you may possibly start thinking more consistently that might be it has got invasive aspergillosis. But in case of the critical care group, critical care means 80% invasive candidiasis and 20% in case of the invasive aspergillosis. So in case of this, of course, in India, we have a mucor issue is also there in case of critical care. Now, in case of the Candida, this is being detected, but if you say that it is being positive in all fungi except crypto and in case of the mucor. So in other situation, like suppose the patient with histoplasmosis, if there is beta-D-glucan positive, it can become positive because it is being present also in this. So it's a pan-fungal marker. So, but the thing is that we, in case of the critical care group, we discussed mainly with Candida and in case of pneumocystis.
So,
yes,
so it needs to be interpreted with the background of clinical context.
Yeah, absolutely. What I said is, again, I want to utter the same definition. This is not a categorical diagnosis for this. It is a more of a vicinity. So it all depends on what is the risk chance. Means in the high risk group, all the biomarker has got much value. But in case of the low risk group, it's very less. Like suppose in your ICU patient, we can do the risk stratification. You have got only ICU admission. And another end, you have got a patient who have got major abdominal surgery or multiple perforation is there, where the chance of the candidiasis is much high. And in that case, if it is beta-D-glucan comes positive, we must be very serious about it. But simply a patient who is in ICU, who has not certainly the risk group wise is not very high, which generally is around 1 to 2%. Just a beta-D-glucan without any blood culture positivity for Candida, I will not consider so strongly for this disease.
Right. So having said that, as far as invasive candidiasis is concerned, sir, beta-D-glucan is specific for few of the Candida or all species of Candida?
Again, there is very interesting fact. Generally, it is for all Candida, but there are the Candida species which are causing infection. Amongst these 3 species, especially Candida krugii, Candida parapsilosis, now Candida auris, where beta-D-glucan don't go very high. It is much high in case of albicans, tropicalis. These are the much high. So this is, we must be careful in this aspect, saying that, okay, beta-D-glucan has come negative and you should stop the therapy. In this scenario, like suppose Candida auris, it can be negative.
Right. So continuing with the same, we'll just first finish beta-D-glucan. Which are the false positives and which are the false negatives? That it is there, but it becomes either positive or negative in absence and presence of fungal infection.
You know, in case of the false positivity, we can categorize some way. Categorize means first medication. Many drugs, even colistin. Of course, we have got this, if you look into these peptides, there can be peptides positive, can positive both. In case of galactomannan also, it can false positive. And many, like even in case of the amoxicillin clavulanic acid combination, that can come positive in this. So that is first in case of the medication. Then I would say that next point is the infusion. Infusion means what I'm trying to say is that if a patient is on antibody, if there is some antibody infusion which have been given, there is a chance it can come positive in that sense. Then third, I would say that in case of the, say, if a patient is having major abdominal surgery, and it's very interesting, you know, there is false positivity has been shown to be if it is a open abdominal surgery compared to if it is a endoscopic surgery. That's a very interesting facts have been shown, very good paper is there. Next, I would say that in case of the bacterial infection, certain, especially gram-negative bacterial infection, where beta-D-glucan can become false positive. And this particular beta-D-glucan can be positive, especially even there is one small thread of gauze is being contaminated, that would give a false positive result. That's why the test has got a lot of bearing with the pre-analytical, analytical, and post-analytical. Pre-analytical means how you collected the blood. Whenever you are collecting the blood for beta-D-glucan, you must use large amount of antiseptic so that you don't do the rubbing. That gives you false positivity in case of this beta-D-glucan. So these are the certain things which where beta-D-glucan comes positive. And beta-D-glucan, I would say that many other, like suppose if you are doing hemodialysis, there is the filter where there can be so many things has got glucan which is being positive. So just a report should not be taken into consideration like that. And if I have to say about the false positivity, false negativity, hyperpigmented. Because if it's a jaundiced patient, if there is hyperpigmentation, that can give false negativity. Similarly, if the patient is on antifungal, that can give a false negativity in that. And already I've seen some of the species like Candida auris where that can be false negativity, which can be there. So these are the certain things. Of course, test method, that is also very important factor.
Important, yes.
And the cutoff value, that would be also important in case of false negativity or positivity. So this is in case of the, I would say in case of the beta-D-glucan. At the same breath, if I have to look into the galactomannan, which you asked.
Sir, before we go for galactomannan,
okay,
there are two questions that I would like to ask. As far as beta-D,
carry on.
Sir, you said that a certain gram-negative infection can also cause false positive. So, any particular gram-negative infection?
Like alkalogen is one of the agent where it had been shown to be quite false negative. Alkalogen, false positive. Alkalogen fecalis. Alkalogen fecalis. That is the one common thing.
Right. And as far as this false positive is concerned and true infection, is there any level difference in the cutoff value or levels that that we can differentiate, that lower level with maybe plus minus clinical context with if these factors are there, probably we might reconsider something like that?
The patient should not be considered on the basis of, say, I would say cutoff value is 80. You say 79 is negative, 81 is positive. Here the thing is that what happened, that those who are really positive, they go in very high. They are 200, 500 like this, very high.
Right.
Similarly, those who are negative, they are less than 30, that would be there. So if you have something coming around this 79, 80 or this, try to do the test again. So that would be more important rather than considering, okay, this is below 80, 79, so it's negative, or this is 82, so it's more than 80, give positive. So this should be in...
so in case of doubt, 2 consecutive levels at the maybe interval of 6, 12 or 24 hours are adding more value rather than just...
Absolutely. Tempting is that you always justify your antifungal therapy. Now you want to take any of the report positive so that at least you can justify your therapy. And people generally say, okay, blood culture, you say that it's not positive more than 50 to 60% cases. So beta-D-glucan has come positive. So I have started antifungal. I would say that consider the group, the risk group, which is there. If it is the risk group high and consecutive 2 samples positive, then you start about this antifungal on this basis. Generally, we use beta-D-glucan rather because of high negative predictive value. We use it to stop the therapy rather than continue with the therapy. That is there.
So it is like kind of procalcitonin, that rather than diagnosis, but it does carry more value in diagnosis as compared to procalcitonin.
Procalcitonin is more in case of the, yes, you are to a certain extent right, that procalcitonin, the non-specificity or Basanian factors are much more. Beta-D-glucan specific, because procalcitonin, where it is liberated, it is the host liberating. It's a action to the host, whereas this is coming from the fungus. So there is a big difference between these two in this aspect. Why we are giving bit more importance to beta-D-glucan rather than procalcitonin.
Right. The same way, sir, as you described beta-D-glucan, let's go ahead to discuss about the galactomannan. the false positives and false negatives, and which are the fungi which are particularly more sensitive and specific to this?
Galactomannan is a test for Aspergillus. That is, you cannot say that this test is for histoplasma, though I have said about it. This is because when you have no histoplasma antigen test, this is a surrogate marker, you can use that part. But in general, Galactomannan is for Aspergillus. Though it can come false positive, as I have said, some of the fungus, like in case of Penicillium, Fusarium, this can come positive. Alternaria, some of the black fungus also, it can come positive. If I say false positivity in case of the Galactomannan, again I go by the same way. First, if I have to say medication, of course it is that same beta-lactam. Though peptides, where it has been said that present a newer test, which are newer kit which had come, it is less cross-reactive. It is less cross-reactive, but it is not zero cross-reactive. So it is still, there is a cross-reaction. People believe, okay, it's completely off. No, you should be careful that whether there is peptides there or not. Second thing, infusion, that is plasmolyte. If you are giving plasmolyte, there can be really chance of this, which can be false positive. Then in case of the bacteria, bifidobacterium, that is one of the issues, that is can give false positive. But I would say that false positive, I would not consider, suppose if it is coming positive in case of the histoplasma, you say it's a false positive. Yes, it is not, it is a more of a surrogate marker. So I am not putting that way so strongly that it is false positive in that sense. And most important thing is the food. Pasta. And there is a very important paper which has been published quite long back in New England Journal of Medicine about a case. The patient was a high-risk group patient who the Galactomannan has gone up, and immediately they have started giving the antifungal, but their lung is completely clear. So they were very curious where from it had happened, because mostly it is the lung which is being first affected. Then they came to know the patient has taken ice pop. Taking ice pop, ice cream or something like that, this also gives false positive. So you have to be a bit careful in case of the Galactomannan interpretation in this aspect. So these are the basically Galactomannan false negative. Major issue is that if the patient is on antifungal, that is specifically the prophylaxis. It's not so much in case of the critical care group. It is more important in case of the neutropenic patient, where it is giving the false negative. That is because of the the patient has got already in prophylaxis, that is there. So this is, but of course, again, this is being false negative in case of the test method and all those which are there. So these are the aspects which can be there.
So friends, you need to take history that what patient is eating if you're, sending Galactomannan simultaneously. Otherwise, we may have been in trouble. But yes, clinical context, as sir rightly said, it is more important. So sir, another question about Galactomannan is, like you mentioned Bal Galactomannan, which is more sensitive specific or as compared to serum if patient is not on antifungal so far.
No, I would say again that in case of the critical care group, as serum Galactomannan is not so much sensitive, it's in case of the, say, COVID-associated pulmonary aspergillosis, it has shown to be less than 25% positive. So I would say that in critical care group, this BL Galactomannan is much more useful because it has got much better sensitivity and specificity compared to the serum Galactomannan in this aspect. So we generally prefer to do it. Critical care group is very interesting group. Here, if we have isolated aspergillus from BL sample, you cannot say that this is a patient who is having invasive aspergillosis because it's a colonization. But when we have same BL sample positive for Galactomannan, we say it's more likely to have the infection. The reason is in the Galactomannan comes out when the fungus is actively multiplying, or it's not colonizing only, it's multiplying and it's invading the tissue plate. So that's the reason we give in BL sample, not so much in case of aspergillus positivity rather than BL galactomannan. That's, I'm saying clearly non-neutropenic group. Don't misinterpret me in case of neutropenic group. Neutropenic is completely different thing.
Different, right. So, sir, as Bal Galactomannan, any role of CSF Galactomannan?
Yes, CSF Galactomannan has found to be, all the papers are showing very good result. But still, you know, we all are our boss is USA FDA. Until unless US FDA approve it, we don't have the, because ultimately, you know, where you people face the problem is the insurance issue. Suppose if you have started something, people will ask, is it FDA approved? So that's the problem which we face in case, but 100% that the CSF galactomannan is a very good test. We need to introduce this much more, especially when we have in India, we have mold infection in the CNS is quite high compared to the Western one. That's
right.
very important.
Right. So, sir, regarding both Beta-D-glucan and Galactomannan, two common questions. That, as you said, that patient is on piptazo, and this may be false positive. What happens? It's a lab-related assessment issue, or something happens inside body?
See, the thing is that in the case of piptaz, this has got the cross reaction. What we are trying to detect, you are trying to detect, this is a ELISA method which we are trying to detect this particular antigen. If it is a cross-reacting, so you get a false positive. That is the usual thing which have been there. So if these are the, again I would say that suppose if you have patient is on piptaz and galactomannan is coming around 8 or 9 value, I would not consider that it is a false positive of piptaz. So these are all come when we are considering say 1.5 or say suppose in serum 0.7, considering that it is positive or not. In those conditions, there is a chance of cross-reaction which can give marginally high positivity. But if you have got say suppose 5, 6, 7 galactomannan, I would say definitely there is more likely to have this infection which is in there.
Right. So another common question for both of these biomarkers, do levels correlate with severity?
You know, there is a lot of debates on this aspect because not only severity, it is also monitoring. Like suppose if you are giving therapy, whether it can help in case of monitoring. I would say that amongst these two, the Beta-D-glucan has much more sensitive, means it goes up and then it falls when there is a response to therapy. So you can try in case of this, but galactomannan index, people have found that it is not so well correlating with the disease severity or in case of the monitoring the therapy. Of course, generally, but it's again a debatable question. Like there are certain people in case of UK, they considered, no, we should consider is as important. So it's a question of individual, but of course, suppose a patient who is having 7 galactomannan, and after therapy a week or 10 days, it has come down to say 2. I would say that this is definitely a response. And of course, it is being shown that a patient who is having high galactomannan and considering another patient who is low galactomannan, the mortality chance is more in the high galactomannan level. So those are the factors are there, but at the same time I put those caveat also that yes, severity and monitoring can be done, but these are the caveat which should be taken.
Right. So extending the same question, you said that yes, it can be an indicator of therapeutic response. Can we use it as a marker of stopping therapy? Maybe after 10 days or 14 days?
This is in case of Beta-D-glucan.
Because
Beta-D-glucan, not in case of galactomannan. Beta-D-glucan is very importantly, it is, say, suppose having good negative predictive value, especially in case of the ICU patient. even if you see the recent Candida guideline, which have been published, global guideline, there also it has been, though it had not been put as A, but it had been put at least B, means moderate recommendation which have been given that you stop therapy on the basis of the beta-D-glucan negativity. So that is very important in this issue. Because,
And so as far as...
sorry, I am saying moderate, the reason is there are some 20% patients where it can come false negative.
Yes.
So that's the reason people are concerned, especially now we have got quite high number of cases in case of the Candida parapsilosis infection. We have high number of cases of Candida auris infection where beta-D-glucan is not so high. That's the reason they have not put into the A category. They are put into the B category. This is moderate recommendation.
So can be considered along with the other, most importantly, therapeutic response. Right? So is there any particular, I would say, based on this serial monitoring, especially beta-D-glucan, you rightly said that you can serially monitor and use that as therapeutic response and maybe sometimes stopping of antifungal. But what about the general duration of antifungal therapy in non-neutropenic patients?
See, in non-neutropenic patient, there is which patient, how long the therapy should be given. There is, in case of Candida, it has been said that if it is negative blood culture, then you should continue for 2 weeks therapy. Now, recent paper which had come, which is going to be 10 days therapy. So instead of this one, they are slowly reducing it, the number of days post negative condition. But if the patient, suppose you have started therapy without positive blood culture, and which is a very common fact in case of intra-abdominal candidiasis,
yes,
then there is a big issue how to do it. So there it is said that the galactomannan, possibly beta-D-glucan is a very important factor which can decide you when to stop the therapy in these cases. But general therapy in case of the candida is not more than 3 weeks. But in case of aspergillus, depending on the site, say suppose if it is a site of CNS or somewhere where it is invasive disease and strongly, then possibly even if you have to go for therapy for months together. That is being common. So there is no clear-cut recommendation, but it is depending upon the clinical factor, radiological factor, and also the mycological factor. You have to take a decision. So it's a more of individualization of the patient where you can stop the therapy.
Right. Sir, one take-home message, suppose if you want to convey when to get these markers done. Either beta-D-glucan or galactomannan.
See, the thing is that in case of the beta-D-glucan, any patient with sepsis, in the case of your ICU, first you see in your local epidemiology. If your local epidemiology shows that Candida positivity rate is around 20 to 25% of all sepsis cases, possibly you have to give the order immediately. And if it is not so much, but if you have started empiric therapy, then you have to order simultaneously or before starting the empiric therapy. That is a must in this scenario. But in case of the, say, suppose in an ICU patient, which is not so high in chance, and there is a chance that patient is having fever, not responding to antibiotic, you are thinking to start antifungal, but before that you can do a beta-D-glucan test with her. But beta-D-glucan, again, in this scenario, if it comes positive, it does not help you in diagnosis, but negativity rather help you in exclusion of the disease that is there. So this way you can decide about it. In case of beta-D-glucan, sepsis immediately, and in case of others, when the patient not responding to 3 days antibiotic therapy, especially in case of fever-driven approach. In case of the galactomannan, it all depends that suppose if the patient is having respiratory symptoms and patient has got these risk factors, now it has been categorized. Like say patient is having COPD, patient is having cirrhosis, patient is having respiratory viral disease. So these are the conditions. Patient is having influenza. So these are the certain criteria where you start thinking that there is a chance of more of invasive aspergillosis. Now, in this patient, if there is a clinically patient is having respiratory symptoms, then you have to think about starting this aspect or doing this test. And beyond that, if there is any new infiltrate come in the imaging, these are the all factors together. You start thinking, oh, this is a chance that it can be fungus, and fungus means it's more likely mold infection, and then it is very it would be prudent to do a Galactomannan test in that scenario.
Right. Sir, now we are coming to an end of it, and we always look for future, that what is going to be available bedside, which is, possesses the property of near ideal. No, ideal is not possible, but near ideal biomarker as far as critically ill fungal infections are concerned. So what are the future biomarkers that may come in maybe subsequent time?
This is omics technology is being used. Omics means one side is the proteomics, other is the genomics. Now, proteomics technology is bringing, as it is being found, one important test of point of care, that is lateral flow assay. Lateral flow assay is now very importantly being used in case of aspergillosis, because it is a point of care test, gives result within 15 minutes. Even the sensitivity is 60%, is very useful if the specificity is good. We have done the specificity evaluation multi-center. We found this is very good specificity, but sensitivity low. But sensitivity 60% is also good for a point of care test. Then we look into this genomic aspect, but there are, of course, we have now developing in case of mucor, because our Indian mucor happens in case of the diabetic group, which is not so immunosuppressed. So we have now found one antibody and antigen test, which we have just put into a patenting, and already one paper has been published showing that how it is good in case of doing mucor about it. And next two papers are going to come. One of the PhD student had done very good work on this aspect, and it is being evaluated in more centers now. So this is one antibody test can be useful. But if you look into the other tests, like suppose Mannan anti-Mannan, Candida germ tube antibody test, people ask me about all these things. All these tests, like suppose Mannan anti-Mannan is more commonly being used in case of Europe. Candida, this germ tube antibody that is being developed at Spain, and that is used mainly in case of this Spain. It's not giving additionally better result. Of course, if you combine, it can give this. So how many tests you can do? That's another issue which is being there. And moreover, in case of the antibody test, it is a combination of both antigen and antibody. It may not be so easy to handle. So these are the issues which have been there. But in case of the genomic technology, of course, everybody speaks about PCR. PCR has already been standardized in Aspergillus, but it is in neutropenic group. In non-neutropenic group, we still are not doing Aspergillus PCR. But mucor PCR is coming to be very soon, which have been there. But there are other tests which are coming up. Say, suppose, I would say that in case of Candida is the T2 Candida which had come up. T2 Candida, but is really, it has brought down the turnaround time from 4 days or 3 days to only 4 hours. And this particular test only detects 5 species of Candida. That is our problem. When we had multicentric study of Candida in our country, we saw there are 31 species. That is one. Second is each test costs $300. So that's another major issue in case of even Europeans, they are not using this test. And this is one of the tests, very good test. At least quality of test wise is very good. Then people are working with the issue of this, say suppose of the multiplexing. You have seen several of the companies putting together bacteria, fungus. Any multiplexing has the problem of going down of the sensitivity. That is the major issue in case of the serum going for this. Fungus is very small in quantity. Say compared to virus and bacteria, the quantity of fungi at the site of infection is very less, and it is being remaining at a site. It is not dispersed like in case of bacteria and virus in the blood. So that is one issue which is being there. So we need very sensitive tests, which is not there. Now, whole genome sequencing, yes, that is also being used in case of trying for this aspect. But the thing is that, again, these are all in the process of standardization. But where I am more really thinking the future is the metagenomics. Two aspects.
Yes.
One is the microfluidic assay, which has brought the lateral flow assay. Another is the this metagenomics, which is giving
Yes.
the any bacteria, fungus, free DNA detection. That is being coming, like in case of cancer diagnosis. It's coming
Yes.
up very good metagenomics. So these are certainly in case of future, but certain other tests, like suppose people say IL-18, interleukin 8, sorry, 18, not 8. Interleukin 8 is very correlating with the invasive aspergillosis. But I say that these are all statistics more rather than helping us in case of real patient practice. That is there. But if you ask me, my bet is in 3 areas. Where it would come. One is the lateral flow, and second is whole genome sequencing, and third is in case of this metagenomics, that is in case of the cell-free DNA. That would come in future very soon.
Right. So let's hope that, it reaches our bedside prescription of this kind of investigations, at the same time being cost effective, because it is equally important for our part of the world. So that ends our podcast with our, kind of fungal man of...
Just one comment I am saying you. When you said that it should be cost effective, what is the cost effective? What is the cost of your echinocandin?
Mindset. It's a mindset.
No, I am again saying one echinocandin costs you around 12,000 rupees per day testing.
Yes.
And none of the tests is more than 8 to 10,000. So I am saying you, which is rational. That's people don't think about. Oh, this cost test of
lending cost, people think, but either starting or stopping therapy, that makes a huge lot of, there is incomparable cost difference.
Exactly.
Yes,
I will say that part is there.
Right. Thank you, sir. Thank you, Dr. Arunaloke Chakrabarti, sir, kind of fungal man that we call him. So, and having you here is an honor for all of us, and to interview you with this podcast is, is kind of lifetime memory. So I thank ISCCM, our current president, Dr. Srinivas Samvedam, our current general secretary, Dr. Sachin Gupta, and our president-elect, Dr. Ranveer Tyagi, for allowing us to interview this kind of relatively, short, rather than, any PPT presentation, interview with experience and evidence club. That is most important. That definitely relays more and more messages that we can utilize at bedside. Thanks once again, sir, for accepting our invitation.
Thank you, and also thanks to ISCCM. The all people, I don't want to name the people, all of them are very good friend of mine. Thank you.
Thank you, sir. Thank you.